Thank you very much, Dr. Maged Salah, for organizing this event. And I also would like to thank the chair of the department, Professor Dr. Ayman Dessouy, and special thanks to Dr. Saad Al-Mahdi for making this event possible. I would like to welcome everyone from the audience from all over the world. I also like to welcome our dear speakers. We have 4 eminent speakers. I think this meeting will be a very fruitful one. I hope you will enjoy the evening with us. Okay, our first speaker will be Professor Dr. Amr Abdelmonem. Dr. Amr is a very special guest. He is a very good friend as well. He is a professor of anesthesiology and ICU at Cairo University. He's also a professor of clinical nutrition. He is going to talk to us about enhanced recovery after cardiac surgery, evidence-based guidelines for perioperative care. Dr. Amr.
Much obliged. Thanks, Dr. Hosam, my dear friend and colleague. It's always my pleasure to participate in the scientific day of our unit. And I would like to thank Dr. Maged Salah for his sincere effort in organizing this scientific activity. And also, I would like to thank very much Dr. Saad Al-Mahdi for improving the learning tools and to facilitate the learning and the education in this era. So let's proceed with advanced recovery after cardiac surgery, evidence-based guidelines for perioperative care. Actually, we should praise Professor Henrik Khaled, Professor of General Surgery at Copenhagen University, the one who introduced the concept of ERAS into medicine. Actually, ERAS is a and I believe that all anesthesiologists are familiar with Professor Henrik Khaled. The concept of ERAS is the multimodal and the multidisciplinary strategy. It's all about limiting the neurohormonal response to surgery, optimizing the patient satisfaction, reducing post-operative complications, and in-hospital length of stay, and for sure, to optimize the patient's management. This is the concept of ERAS. Actually, we have a lot of recommendations and guidelines by ERAS Society, yet for non-cardiac surgery. In cardiac surgery in 1990s, attempts were made to modify the perioperative management in patients undergoing cardiac surgery. And it was called the fast track. The fast track enables the early extubation and reducing the period of mechanical ventilation. And thereafter, the concept of ERAS in cardiac surgery moved on, yet stumblingly. And then in early studies, the ERAS approach showed promise in cardiac surgery. However, evidence-based protocols have yet to emerge until 2019, where the ERAS Cardiac Society endorsed the guidelines for perioperative care in cardiac surgery. Actually, these guidelines are the bundle of strategies that cover the preoperative period, intraoperative, and post-operative period. And let's go for the preoperative period. The first recommendation is preoperative measurement of HbA1c, or glycated hemoglobin. Based on moderate quality evidence, the preoperative measurement of HbA1c is recommended. However, we should ask this question: if there is sufficient evidence to recommend an upper limit of HbA1c prior to cardiac surgery, when to postpone your surgery, who is going for cardiac surgery, or a patient who is going for cardiac surgery. Unfortunately, there is no sufficient evidence to recommend an upper limit. This is an area of debate in cardiac surgery. And also, it is unclear whether preoperative interventions in patients undergoing cardiac surgery will result in improved outcomes. So we should ask this question: why should we measure HbA1c? We measure HbA1c for risk stratification. First, we have to rule out whenever you have a patient with high HbA1c, more than 7 or 8 or 9%, you should rule out cardiac autonomic neuropathy. That high HbA1c reflecting poor glycemic control plays a central role in development and progression of autonomic dysfunction. And the cardiac autonomic neuropathy is associated with intraoperative cardiovascular instability. How to rule out the cardiac autonomic neuropathy? At first, there is decreased heart rate variability and resting tachycardia thanks to the parasympathetic denervation and hypertension as well. Thereafter, there is denervation of the sympathetic nervous system in addition. It will end up with impaired exercise tolerance and orthostatic hypotension and prolonged QT interval. We should rule out prolonged QT interval in any patient with high HbA1c. This is a predisposing factor for polymorphic ventricular arrhythmias and torsades points. Whenever we have prolonged QT interval preoperatively for cardiac surgery, we should be alert for these three some hypokalemia, hypomagnesemia, and never to use the amiodarone. Okay, concerning the glycation, does only the glycation affect the hemoglobin or other proteins? Other proteins can be glycated like collagen. Whenever the collagen is glycated, there may be a positive Prayer sign. Positive Prayer sign means that the patient cannot approximate the palmar surface of their hands. Therefore, this sign can predict the difficult intubation. And glycation of albumin as well. Albumin is the main carrier of the intravenous anesthetics. So whenever you have HbA1c above normal, you should suspect the glycated albumin that may affect the unbound effect of the unbound fraction of the intravenous anesthetics that may end up with profound effects on hemodynamics. The second recommendation is, or in the guidelines for ERAS cardiac surgery, is the preoperative measurement of albumin. Based on moderate quality evidence, it can be useful to assess preoperative albumin before cardiac surgery. Albumin for risk stratification. Albumin is a prognosticator factor that can predict acute kidney injury, prolonged mechanical ventilation, and hospital stay. The third one is preoperative correction of nutritional deficiency. Okay, we measured albumin preoperatively, and albumin level is less than 3 grams per deciliter, or our patient with BMI less than 18.5, or with weight loss more than 10% in the previous period, regardless his BMI. This is a case of malnutrition. Should we correct this nutritional deficiency preoperatively? The answer is yes. Correction of nutritional deficiency is recommended whenever we have a space of time. If we have a good space of time, it's better to supply or provide our patients with intensive nutritional therapy, and mainly with oral replacement therapy for 7 to 10 days preoperatively. If we don't have enough time, this is the time for albumin infusion to raise up the level of albumin above 3 grams per deciliter. And the fourth recommendation is, what about the consumption of clear fluids before general anesthesia? This is an important element in the ERAS. We all know that clear fluids may be continued nowadays up to 2 hours before general anesthesia after the end of the dogma of don't give your patient any liquids till 6 or 8 hours before surgery. Now you can give clear fluids for 2 hours before general anesthesia. However, in cardiac surgery, we have two concerns: diabetes mellitus and use of TE. Though aspiration pneumonitis has not been reported yet, this potential remains in patients undergoing cardiac surgery who have delayed gastric emptying. Therefore, we should judge our patients separately. Every case should be judged before advising the clear fluids to be continued up to 2 hours before general anesthesia. Concerning the preoperative carbohydrate loading, as we know, preoperative carbohydrate loading is an emerging component in the concept of ERAS. Why? Why we are not feeling well with the fasting? fasting induces lipolysis with the release of free fatty acid. And this free fatty acid can induce insulin resistance, as well as fasting stimulate the gluconeogenesis by the glucagon hormone. And one of the important substrates for gluconeogenesis is alanine, coming from the type 2 muscle fibers through the process of proteolysis. And therefore, gluconeogenesis will end up with the production of glucose. If we have a patient with insulin resistance and increased production of glucose, this is a case of high blood sugar and increased protein catabolism that may jeopardize the patient course intra and post-operatively. Therefore, the concept of carbohydrate loading is to increase the insulin level preoperatively to antagonize the glucagon and repressing the gluconeogenesis and the proteolysis. However, does this mean that it affects the insulin resistance? The answer is no. It might repress gluconeogenesis and the proteolysis and still does not affect the insulin resistance. So, given the current minimal supportive data in patients undergoing cardiac surgery, carbohydrate loading is given a weak recommendation. Actually, for our patients undergoing cardiac surgery, many of them suffers from metabolic syndrome preoperatively. If you have a patient with metabolic syndrome and you load him with carbohydrate, you may increase the insulin resistance and not to reduce it. And this case, we should not preload our patients with metabolic syndrome with carbohydrate. Concerning the patient engagement tools for education and learning our patients about the goals of the surgery, the procedure, and in order to reduce the fatigue, the anxiety, and the enhance the recovery and reduce the hospital stay. This patient engagement tool should be undertaken whenever possible, either through direct patient contact or through imprinted materials or online application. Concerning the prehabilitation, prehabilitation is a very important component of ERAS. However, in cardiac surgery, we don't have a space of time with different type of surgeons, different type of patients, with different type of signs and symptoms. So cardiac rehabilitation program should include education, nutritional optimization, exercise training, social support, and anxiety reduction, although current existing evidence is limited for rehabilitation. Concerning the smoking and hazardous alcohol consumption, consumption of smoking and alcohol should be stopped 4 weeks before elective surgery. However, this may not be feasible in urgent or emergency setting. Actually, smoking and alcohol are associated with respiratory, metabolic, bleeding, and infectious complications. So cessation is substantial. Let's go for the preoperative anemia. However, preoperative anemia is not graded in the ERAS protocol, though it is very important. Actually, prevalence in cardiac surgery patients of anemia, the level of anemia that we should say that this patient is anemic by WHO is less than 13 grams per deciliter for men and 12 grams per deciliter for women. If we have a patient less than 13, from 12 to 13 grams per deciliter, actually the prevalence of this anemia is from 16 to 54%. And for patient less than 10 grams per deciliter, the prevalence is 5.5%. This is a high prevalence. And actually, anemia is a risk factor of complication and mortality. Evidence-based medicine clearly discourages qualification of patients with anemia for elective surgery. And so what to do? It's better to correct anemia preoperatively. Either if we have a space of time, we can provide our patient with oral ferrous iron for 4 to 6 weeks, or we can go for intravenous ferric iron with erythropoietin for few days before surgery. And if the patient with less than 10 grams per deciliter, blood transfusion should be considered, unfortunately, with its consequences on the course of the patient. From previous studies and not evidence-based, premedication with benzodiazepines that increase the risk of delirium should be reviewed. So what is the recommendation? I can say recommendation or from the literature, it was found that premedication with pregabalin administered in a dose of 75 pregabalin, this is a gabapentinoid that suppress the voltage-gated calcium channels and repress the excitatory neurotransmitters, can be given a dose of 75 milligrams to limit the morphine requirements and reduce the incidence of chronic pain as a pre-medication. Okay, let's move on to the intraoperative strategy. Concerning the first one is the surgical site infection reduction. There is a care bundle intervention to reduce the surgical site infection through topical intranasal therapies to eradicate the Staphylococcus aureus infection. Actually, 25% of cardiac patients undergoing cardiac surgery are carriers of Staphylococcus aureus infection. And the use of cephalosporin infusion fewer than 60 minutes before skin incision, and never to forget that we should redose for cases longer than 4 hours. Skin preparation is of substantial importance, and depilation protocol using the clippers rather than shaving, with dressing every 48 hours. Concerning the hyperthermia, actually, when we are going to rewarm our patient at the end of the cardiopulmonary bypass before weaning, hyperthermia means that core temperature is more than 37.9 degrees centigrade. It's associated with cognitive deficits, infection, and renal dysfunction. The recommendation is rewarming on cardiopulmonary bypass to normothermia with continuous surface warming. And what about the conventional way or the heat exchanger? We have 2 options. Either to increase, we limit the goal of rewarming at the cost of postoperative hypothermia, or we can prolong the cardiopulmonary bypass to limit the rate of rewarming. And both have many consequences. So the recommendation is to use continuous surface warming. Concerning the cyclocapron or tranexamic acid, epsilon aminocaproic acid, the maximum total dose of 100 milligram per kg is recommended. And based on this evidence, this drug is recommended during on-pump cardiac surgical procedure. Okay, goal-directed fluid therapy is an emerging component and the key element in any ERAS protocol. So goal-directed fluid therapy, which means that we have to optimize the fluid or the volume status of the patient to avoid hypovolemia with its consequences on perfusion and mixed venous oxygen saturation and oxygen uptake, and also to avoid hypervolemia with its consequences on the interstitial edema and inflammation. So trials consistently demonstrate reduced complication rates and length of stay in surgery overall, specifically in cardiac surgery. And the use of TEE will be very useful at this situation. Glycemic control. Okay. The blood concentration of glucose should be maintained within the limit of 140 to 180 milligram per deciliter through insulin infusion. So why should we focus on this limit in particular? Actually, if the myocardium is stressed or ischemic, it will not depend on fat as the main metabolic fuel. It depends on the glucose as the main metabolic fuel to be oxidized in aerobic way. So we should ensure that the myocardium is receiving the proper concentration of glucose. This is the main metabolic fuel. If you have high blood sugar above 180 milligram per deciliter, this means that there is no proper entry of glucose to the myocardium thanks to the insulin resistance. So you should infuse insulin in order to ensure this proper supply. Concerning the lung protection, though, it is ungraded as ERAS protocol, though it is important in fast tracking and post-operative ERAS strategy. The tidal volume should be calculated based on the ideal body weight, height in centimeter minus 100. It's an average of 8 should be administered, average of 8 ml respiratory mixture per kilogram, and PEEP should be maintained at the level of 5 centimeter water, and not to forget the driving pressure, which is the peak in respiratory pressure minus PEEP. This driving pressure should be below 16 centimeter water. And now let's finish with the post-operative period. Concerning the pain management, there is sufficient evidence to recommend multimodal opioid sparing. The ERAS always is concerned with opioid sparing effect. Give drugs that to facilitate the process of transfer from the ICU and from the hospital itself. Therefore, it's recommended to use the multimodal opioid sparing. However, no single pathway exists. The acetaminophen is the drug of preference thanks to its very high profile of safety. And the tramadol, which with opioid and non-opioid effect, however, high tramadol dose can end up with drowsiness, dexmedetomidine, pregabalin. So a cardiac surgery program can use either of them according to availability. Let's move for the post-operative systemic delirium screening. What is delirium? Delirium is a fluctuating mental condition with disorganized thinking and inattention. This delirium is very common in cardiac surgery. Up to 50% of patients undergoing cardiac surgery may suffer from delirium. However, there is no evidence that prophylactic antipsychotic use reduces delirium. So the recommendation from non-cardiac surgery is at least one delirium screening per nursing shift in order to investigate and to detect and to implement the treatment. Concerning the hypothermia, hypothermia is associated with bleeding, post-operative bleeding, and infection, and morbidity and mortality. Therefore, it is recommended for prevention of hypothermia by using continuous surface warming, raising the ambient room temperature, intravenous fluids to avoid hypothermia in the early post-operative period. And chemical thromboprophylaxis, actually, pharmacological prophylaxis should be used as soon as satisfactory hemostasis. We use always mechanical prophylaxis, thromboprophylaxis. However, pharmacological can be added on post-operative day 1 whenever there is a stability of the hemostatic state. There is no risk of rebleeding. Concerning the early extubation, fast tracking was the concept that emerged in 1990s that enables the early extubation within 6 hours post-operatively. In order to implement this strategy, we should use strategies to ensure extubation within 6 hours. So what are these strategies? We should use inhalational anesthetics with lower blood and tissue solubility, like we can use the sevoflurane or desflurane. Propofol in a dose of 3 milligrams per kg per hour, and opioids with short duration of action and intermediate acting muscle relaxants. Kidney stress, acute kidney injury, I believe my dear colleague and friend, Dr. Muhammad Bakri, will elegantly discuss this issue later. So in kidney stress and acute kidney injury, urinary biomarkers can be used, which are tissue inhibitor of metalloproteinases 2 and insulin growth factor binding protein 7. These biomarkers can identify patients as early as 1 hour after cardiopulmonary bypass for those patients who are at risk of developing acute kidney injury. Okay, if we have a patient at risk of acute kidney injury, we should remove the or avoid the nephrotoxic drugs, discontinue ACE inhibitors at least for 48 hours. We should follow the creatinine urine output. We should prevent hyperglycemia and optimize the volume status as well as hemodynamic parameters. And at last, early oral nutrition. This is not ungraded, this is ungraded in ERAS cardiac surgery protocol, though it is very important element and emerging component in ERAS for non-cardiac surgery. Actually, early oral nutrition whenever we provide patient as early as possible with oral nutrition, it will maintain the integrity of the intestine, reduces infection. Intestine is the first barrier against invading microorganisms and reducing the hospital stay. And however, to provide your patient with oral nutrition, you should optimize electrolyte and acid base before providing him with oral nutrition. Otherwise, it will end up with intolerance. And we should avoid feeding the tachycardic patients. We need a low heart rate in order to tolerate oral feeding. This is my home message. Actually, ERAS is all about strategies in the preoperative, intraoperative, and postoperative period. Preoperatively, we should measure the HbA1c for risk stratification, and as well as albumin, and the correction of nutritional deficiency either through oral nutrition or through albumin infusion if we don't have enough time and albumin level less than 3 grams per deciliter. Consumption of clear fluid is always recommended, yet you should judge your patient separately. Carbohydrate loading is of low evidence in ERAS protocol for cardiac surgery. Patient engagement should be undertaken whenever possible to reduce the fatigue, the anxiety, and to enhance the recovery of the patient. Prehabilitation is of low evidence, however, should be undertaken whenever is possible. Smoking and hazardous alcohol consumption should be stopped 4 weeks before surgery. Concerning the intra and preoperative anemia, it should be corrected. Anemia should be corrected preoperatively, though it is not a graded element in the ERAS cardiac surgery protocol. Intraoperative strategies: surgical site infection reduction through bundle of intervention, and hyperthermia should be prevented through continuous surface warming. Tranexamic acid is recommended always with high evidence for cardiac surgery, especially CABG, on-pump CABG. Goal-directed fluid therapy should be implemented always in the ERAS protocol. Glycemic control is of substantial importance to ensure proper supply of glucose to the myocardium to be used as a metabolic fuel. Lung protection strategy is important, though ungraded in ERAS protocol for cardiac surgery. Postoperatively, pain management through multimodal opioid sparing protocol or strategy. Postoperative systemic delirium should be screened, and persistent hypothermia should be avoided. Chemical thromboprophylaxis is provided for the patient with mechanical in the first day postoperatively, provided that there is stability in the hemostatic condition. Early extubation should be implemented, and kidney stress, acute kidney injury should be prevented and managed. And early oral nutrition should be implemented, yet with proper electrolyte, acid-base balance, and heart rate. I'm very much obliged. Thank you.
Thank you very much, Dr. Amr, for the excellent lecture. I have a couple of questions from the audience. First question is from Dr. Yasser Zaghloul. He is asking about the acceptable hemoglobin level for patients going for CABG. What is the acceptable level? And also for patients with coronary artery disease who are undergoing non-cardiac surgery.
Okay, the acceptable level of hemoglobin preoperatively is the level addressed by the WHO, which is 13 gram per deciliter for men and 12 gram per deciliter for women.
So below this level, we cannot undergo CABG. We have to postpone.
No, you don't have to postpone. You have to judge your patient. This is the optimal level before surgery. However, the condition should be judged, and you should evaluate the condition. However, we should be aware that post-operative and intra and post-operative complications will be evident if we did not correct the anemia preoperatively, thanks to the need for intraoperative blood transfusion.
So there is another question. Unfortunately, the name of the attendee is not obvious here. He's asking, is tachycardia a limiting factor generally, or only if it was caused by pain?
Tachycardia is a limiting factor for oral nutrition. If you mean oral nutrition, yes. Don't feed your patient with oral nutrition. If he is tachycardic, he will not tolerate.
But it's not, it's an indication for undergoing or postponing. Is there a clear guideline? Is tachycardia a factor, a limiting factor for going or postponing cardiac surgery in general, or is it not?
No, it is not a factor for postponing cardiac surgery.
Okay. A question from Dr. Hilal Siddiqui. If some is already on pregabalin, 75 milligrams, twice daily, should we reduce the dose or alter the dose?
No, we should not reduce the dose. Should go for the surgery without reduction of the dose.
A question from Dr. Majid Mohammed. What about desmopressin if patient is taking aspirin and Plavix?
Desmopressin?
For patients taking aspirin and Plavix.
Okay, well, desmopressin has nothing to do with the ERAS protocol. So it's judge your patient accordingly. But desmopressin has nothing to do.
Okay. So I have a question for you. Is there any evidence or any rationale for using opioid-free, a totally opioid-free regimen for patients, and is this beneficial for ERAS?
Yes, it is a very emerging component in ERAS to use the opioid-free multimodal pain strategy, pain management strategy. And the preference is for acetaminophen. Acetaminophen should be implemented always, or should be given for our patients following cardiac surgery.
Okay. Maybe we can have one final question. Dr. Ahmed Khattab is asking, is there any modification in the choice of cardioplegia?
No, there is no modification concerning the ERAS protocol.
Okay. Thank you very much, Dr. Amr.